Interest of time, we'll go ahead and get started. We did have close to 100 individuals register for today's prevention presentation, and so I anticipate additional folks joining us today, but I want to make sure that we're cognizant of everybody's time this morning. So thank you for joining us today for our second prevention webinar during April Child Abuse Prevention Month. My name is Nicole Silliman, Executive Director of the Ohio Children's Trust Fund, and we're excited to be highlighting some of the program that the Trust Fund has been supporting in recent years, as well as highlighting some of our partners throughout the state. Before we begin the presentation today, I want to go over some brief housekeeping items. There is a lot of you with us here right now, and more that will probably be joining us in the near future. So we're asking you to stay muted during the presentation this morning. If you do have a question or a comment, please include that in the chat, and then we'll do our best to respond to it, as well as hopefully have some time at the end of the presentation so that we can have discussions and answer any questions that you may have. If we don't get to a question or a comment for whatever reason, we will make sure to follow up after today's presentation. Additionally, if you need a certificate for attending today's presentation, please include your name and email in the chat, and then we'll be able to follow up with you after the fact as well. Now, I would like to introduce Dr. Alissa Huth-Bocks with University Hospitals Rainbow Babies and Children's Hospital. Dr. Huth-Bocks is a psychologist and professor at Rainbow's Babies, and she will be sharing with you all today about a program they've been running in the Great Lakes area, Attachment Vitamins.
Thank you. Great to be here. Thanks for the invitation to present to this audience. We're really happy to be here. And I just want to say I am presenting on behalf of our whole Attachment Vitamins team. And during the question and answer, we'll get a chance to hear from them as well. Holly Pangrace, who's on, who is a licensed professional counselor, and Jasmine Reed and Chris Cipolla, who are social workers at Rainbow Babies. So that's our whole Attachment Vitamins team, and they are here today also. And so, yeah, we are so excited to talk to you about this program called Attachment Vitamins that we've been running at Rainbow Babies. We're located in Cleveland, and in particular, we are running this program out of a pediatric and a women and children's pediatric and OBGYN primary care clinic located in Midtown Cleveland. So this is operated out of a healthcare setting where we see children in pediatrics and women for obstetric and gynecology care. And that makes it a little bit unique to the setting in which we're delivering this. On the slide, I said no real vitamins involved, because we have had people ask us or get confused a little bit on the wordplay here of like, wait, is there really a vitamin you're talking about? And no, this is just a play on words. And we did not name this program. We'll explain where it was developed and how. It's a play on words, though, to try to emphasize that building attachments early in life between primary caregivers and their babies and toddlers and young children is as important as taking your vitamins. So that's sort of where that comes from. And I know, let me just say one more thing. I'll just have a couple slides of, some background statistics, just to sort of demonstrate, again, the need for programs like this. But I know that I'm preaching to the choir, certainly with the Ohio Children's Trust Fund, who is committed to the prevention of child maltreatment and adversity. And I know anybody who shows up for this is also committed to the prevention of child maltreatment. So I know I'm preaching to the choir, and I don't need to convince any of you, but I do want to just lay the groundwork for Ohio in particular and what we're facing. And so I have a couple of slides before we get to the actual program. I also just, part of these slides, I wanted to do a major shout out to Groundwork Ohio for the publication of their early childhood dashboard, which they just released in 2023. And they have put together multiple different data sources and wrote a beautiful, well, it's like a report that you can get online And I have the link at the bottom. And I really encourage everybody on this call to review the early childhood dashboard. It's just a beautiful synthesis of data and very recent data sources. I pulled a couple of charts from that report. You know, again, I don't need to convince you, but to highlight that, you know, we really all need to be concerned about early adversity and early exposure to potentially traumatic events for young children. And these slides are in particular focused on 0 to 5, which is who, you know, we serve through the attachment vitamins program. The charts show the most recent data available for a variety of adversities and traumas, as well as if data were available to compare it to, what the trend has been over time. So are we seeing it stay about the same, increasing, decreasing, as well as how Ohio compares to the United States as a whole. So sometimes data are available for those comparisons and sometimes they're not. So this first slide, you know, highlights really the high percentages of very young children birth to 5 who are exposed to pretty significant adversity that may actually be traumatic for them, including mental illness or substance use in the household, having a parent who is incarcerated, so absent from the home and incarcerated, exposure to domestic violence, as well as rates of living in unsafe neighborhoods, which can be a traumatic exposure. If people have possibly heard of the Adverse Childhood Experiences Scale, or ACE, we sometimes just say ACEs. This is, you know, again, a list of potential very serious adversities that could be traumatic for young children, certainly that are stressful, if not, you know, traumatic per se. And in the state of Ohio, almost 20% of very young children, 0 to 5, are exposed to 2 or more ACEs already by the age of 5. In the literature, once people reach 3 to 4 ACEs exposure, the likelihood of both short and long-term physical health effects goes up very strongly, exponentially increases. And so to sort of think about kids that are already at the threshold of having been exposed to 2 of these by 5 makes one very, very concerned about ongoing exposure and then the effects, the lifelong effects of these exposures. The chart on the right shows that, not surprisingly, we also see pretty significant disparities in exposure to traumatic events, or ACEs, among different groups. So we see that for Black, non-Hispanic children, 0 to 5, as well as Hispanic children, 0 to 5, there is a moderate disparity in the direction that they are more likely to be exposed to ACEs. And children who are below the federal poverty level, there's a large disparity. So they are much, much more likely to experience adverse childhood experiences. And I know that none of this is a surprise to this audience. More about Ohio. Ohio, per 1,000 infants under the age of 1, there are 30.1 infants who experience maltreatment. Probably not a surprise to any of you that the rates of maltreatment are highest and much, much higher between 0 to 1 than at any other time in life. So babies are at the highest risk of maltreatment by many times as compared to all other years of life. And in Ohio, this is our rate currently, and it has shown a worsening trend over time. So this is the rates are getting higher over time, and we are higher than the national average. There are some other statistics here about the rates of children who are removed from the home and in protective custody, as well as permanency after foster care. Ohio, out of all 51 states and DC, we rank 31 on maltreatment in young children, and higher is worse. So we're up there among the higher end across the country. If you jump down to the bottom part of this slide, the stressful life events or experiences during pregnancy, I wanted to sort of reverse looking at this. This is the percent of women with a live birth who reported stressful life events during pregnancy, which we know also has problematic effects on both mothers' well-being as well as their infants after birth. And so we see in Ohio that about 13.5% of women surveyed reported experiencing traumatic events during their pregnancy. This is a worsening trend over time, so we're seeing increasing rates. And then there's a number of other stressful life events, emotionally stressful events, financially stressful events, and stress related to partnerships. And so you can see the rates, which are quite high, actually, because this is percent of women. Up above, these are some signs of family well-being and resilience, because when we're talking about adversity, we want to also acknowledge that even among families who have a lot of adversity or face a lot of trauma, they also have a lot of strengths. So it's not an either or. And we know the research has really shown that despite a lot of adversity, if a child or a family has a lot of resilience factors, protective factors, and strengths, those things can buffer the effects of the stress or trauma. So they can, it doesn't cancel out the trauma or the adversity. Certainly those things are still impactful on people, but it can help people thrive and be resilient and have high well-being despite adversity. It looks like when you see this, you see family resilience, 82.5% of families who reported in the survey reported having resiliency factors, which is awesome. However, I will show you on the next slide, I think, that Ohio is ranked 50 out of 50. And again, higher is bad for family resilience. So while it does look like a lot of families report resiliency, we are still much lower than other states. And this is all based on self-report. One thing I also wanted to note, and this is another sign of just, we know that early literacy and school readiness is very important, that about half of Ohio parents report that they sing songs or engage in these learning activities or reading to their children 0 to 5. We would want to see that being much higher. So that's a little bit of a concern there, or moderate concern. And yeah, here is that one ranking. So this is disappointing, and we want to really work on building more resilience. So we want to reduce adversity and we want to boost up and increase resilience. So that's my preaching to the choir. I know you know all of this. If you want to review these really recent data on how Ohio is doing, please go to that early childhood dashboard. And by the way, I have no connection to Groundwork Ohio, but their work is great. Okay, the good news. There are things we can do about this. There are a lot of things we can do about this to help prevent adversity and help children and families thrive. And then one of the things we all know, and I know something that the Ohio Children's Trust Fund really focuses on and invests in, is building up positive, nurturing, safe relationships between young children and their parents, because probably out of anything possible, a strong, safe, nurturing relationship between a young child and a parent, any parent, it doesn't have to be biological parent, any significant caregiver, is probably the best immunization for social emotional health and well-being. And so that's where our team puts a lot of effort and energy into building up these strong attachment relationships as early as possible. Even we can start working, Holly does a lot of work with expectant mothers. So even working all the way before the baby's even born to promote these early attachment relationships. That's where we focus our time. And we are trying to help little babies and their primary caregivers build secure attachments. And this is really the sense inside the child that they can trust the caregiver to be there when they need them in times of stress, to comfort, support, and protect them. And like I said, it's probably the strongest immunization or resiliency factor that we can focus on in early childhood. So that leads to, so I will also give a plug, we're talking specifically today about attachment vitamins as one program that can support families and build secure attachments. There are other interventions throughout our state that are evidence-based interventions to help support families who face a lot of adversity and trauma to build these secure attachments. One of the ones that I've seen around the state, maybe the most, is child-parent psychotherapy, CPP. And this is our colleague, Chris Cipolla, is a trained provider of this intervention, but it's a long intervention. This is typically a year or longer of weekly sessions. So this is a higher level of, there's already risk, there might already be maltreatment. This is an intervention to help a family after a significant amount of things have already happened. It is very effective, has lots of research backing it. So I wanted to bring that up for two reasons. One is just to make everybody on the call aware that there are evidence-based infant mental health interventions, and there are people in this state who deliver this. For those families who might need longer term care, maybe already after traumatic events have happened. And the second reason I bring it up is because this intervention actually is the foundation of attachment vitamins, which is the program that we deliver. And so it was developed by the same people, and the principles of child-parent psychotherapy underlie attachment vitamins. Okay, so we're finally at attachment vitamins. So attachment vitamins was developed by several experts in child trauma and attachment at the University of California, San Francisco. And again, they are the folks who developed child-parent psychotherapy several decades ago. In contrast to CPP, which occurs after trauma has already happened and is a longer term intervention model, attachment vitamins was developed to be a primary prevention program. So what can we do earlier to help prevent trauma, really, and it help prevent people from needing CPP? So this is a short-term primary prevention parenting program that is trauma-based, and the whole goal is to promote secure attachment between caregivers and their children, and to prevent trauma or maltreatment within that relationship. Thank you, Ohio Children's Trust Fund. They have been funding us when we decided we wanted to bring this program to Cleveland in 2021. So OCTF was our first funder and only funder so far. And we launched this about 18 to 20 months ago at the Rainbow Center for Women and Children. Attachment vitamins is a 10-week group. So it's a group-based model of care for any parents or caregivers of children birth to 5. We actually go up to birth to 6. So it's basically pre-kindergarten. So it's a group-based model, not an individual client model. For 10 weeks, each session is about 75 to 90 minutes. And again, one of the beautiful things about this is it doesn't have to be a mom, it doesn't have to be a biological parent. This can be anybody who is in a significant caregiving role for young children. It's a pretty new program. The first publication came out in 2018, and the early evidence, so we consider this to be evidence informed, has shown that caregivers who go through the attachment vitamins group program at the end have an increased sense of parenting competence and confidence. They themselves are more regulated emotionally, and they report displaying more nurturing and warmth toward their child. So that was the first publication that has come out. But again, this program rests upon decades of evidence supporting child-parent psychotherapy. So we're drawing from that evidence as well. So once we were funded, our team first, and this would be our recommendation to other people too, our team first completed an online training through the National Child Traumatic Stress Network. And I realize that should be NCTSN, not STN. It's a 4.5-hour online training with 9 different modules. And this is a free training. So anybody can do the online NCTSN training on attachment vitamins. You just have to go to the website and sign up as like a learner, and then you have access to the whole 4.5 hours of training. And I would say it's a beautifully produced training program, even if clinicians weren't going to do the full attachment vitamins program or training. Anyone who's working with young children, I would highly recommend this for staff and clinicians to do the 4.5-hour training. But then we did commit to doing, all of the training and becoming certified to deliver attachment vitamins. So after the online training, we contracted with the developers in San Francisco, and they provided us a 6-hour live training. And that is required to be certified to deliver the program. And then they also, as part of that, provide a half-an-hour weekly consultation the first time each clinician runs a group. So each of us, when it was our first time running a group, would have a half-hour consultation with the attachment vitamins developers. The foundations, like the core foundations and goals of the program, are to really transform how the parent understands the child, how they think about the child, how they understand the behaviors of the child, the emotions of the child, to really be curious and wonder. There's a lot of like, let's wonder, let's be curious about why the 2-year-old is throwing a tantrum or wanting this or needing that. A lot of curiosity. Let's try and understand the internal world of the child. A major goal, of course, is to strengthen the parent-child connection, relationship, attachment, bonding, to promote that reflection about the child. So that was what I was just referring to, sort of wondering, I wonder why he does that. What do you think he's trying to show you? What do you think's going on for her emotionally when she does a behavior? This is reflection about the child. We certainly also want to connect parents into longer term services when needed. So sometimes maybe this 10-week group isn't quite enough to support challenges. So we want to make linkages to, more ongoing services when needed, and overall improve parental capacities for, I'm going to skip the first one for a second, for being attuned to their children's emotion, to be reflective and mindful, that's curious, wondering about the child, to be more regulated themselves in their response or reaction to the child. That's executive functioning. And then going back to the first point here, trauma-informed parenting knowledge, and you'll see when we get to the session material that this is a explicitly trauma-informed intervention. And so later in the sessions, the parents' own trauma exposures are not like deeply addressed, but they're acknowledged and recognized. And participants are encouraged to reflect about how their own adversity and their own traumatic experiences might sort of come into the parenting realm. Like, how might this impact how you understand the child and how you react to the child and how you're feeling about the child? And so we want to improve the capacity for what's called here trauma-informed parenting. Okay, and here is the 10-week curriculum. So this is an intervention that has a curriculum. It has parent handouts. It has agendas. It has prompts. So in a way, it's manualized, but there is a lot of flexibility built into it. to adapt it to your particular group of caregivers. But in general, these are the core topics that are covered across the 10 weeks. So first is talking about attachment. What is attachment? What is relationship? What is connection? The curriculum talks about temperament, the child's temperament. What is it? And they do some activities. Separation anxiety, because that is something that is experienced quite a bit. It's normative that young children have separation anxiety. And usually there are particular developmental periods where we see this more, a lot or more. The group also talks about normal childhood fears, because a lot of parents don't know like what a normal fear would be for, like, from our perspective, this isn't a scary situation, but from a 3-year-old's perspective, it's really scary. So we talk about normative childhood fears and noticing parents' thoughts about when their children are afraid and what that feels like to them. In the 5th session, we cover don't versus do statements. And we're talking a lot about responding to challenging behaviors, because we of course know that there's a lot of really challenging, frustrating behaviors that young children show us just because they don't have the capacities yet to know how to cope with those things. Then becoming a partner with your child. That's, again, very relationally oriented. And then we start, again, you can see this is session 7. We do start addressing how parents own stressful life experiences and protective factors, how they may affect parenting and the way the parent feels or the caregiver feels about the child. During this, deep mindful breathing is taught and practiced during the session, because again, we're trying to help caregivers also be more regulated with themselves, so that they can have more regulated responses with their young children. We also talk about mental health symptoms or difficulties, depression, anxiety, and post-traumatic stress disorder symptoms, because we know that a lot of parents, it's very, very common to have this, especially when you're caregiving for young children. It's a particularly high risk period for mental health struggles. And then we talk about the effects of trauma on children. So again, those are later sessions. You can see sort of more sensitive material, but the group has been together for a while. And so there's trust and connection and support that has been built up over time. We talk again, we keep revisiting the parent's own history, and we they phrase them as stormy moments and angel moments. Stormy moments, or sometimes referred to as background music, refer to those difficulties, those really stressful life events or traumatic events in the parent's own history, as well as we recognize angel moments, which refer to, despite whatever adversity, were there people in your life anywhere, at school, coaches, church, community, neighbors, friends, who might have been protective or supportive. And those are considered those angel moments. And we want to, again, not just focus all on the bad stuff, but also, raise awareness and attention and focus on sources of support, sources of good. And that has been shown to be really therapeutically helpful to people. And then last, there is a big celebration and a graduation where we celebrate, the end of the group and the time together. Then for each session, the sessions are organized the same way. So there is predictability across sessions. And we find, or they have found also, that having sessions with sort of a predictable sequence of events, also is very helpful to people, because really even people, adults, everybody, we all benefit from having predictable schedules and knowing what to expect. So each session is sort of structured this way. And my colleagues who run these groups all the time will have a lot more to add in about this. And I think I'm making really good time, so I might even pause and see if I have missed anything before I get all the way to the end. First, every session starts with a moment of connection. And that's a moment of connection between them and the participant and their child. What was a moment of connection that you had this week between you and your child? And then there's a review of previous weeks, material, conversations, maybe like, hey, how'd that go? You know, if there was something someone was going to do or had coming up, a check-in about that. Then it moves into sort of the topic of the day. So that didactic content, whatever it's temperament, or now today we're going to talk about depression. The group tries to incorporate at least one video each session. So there's a list of videos, and I know our team has been finding new videos actually to add to the original set of videos to illustrate different concepts. And those we try to get to be really interactive and sometimes provocative. Like there's one, you know, a couple I can think of that are hard to watch of a parent and young child having some challenges. And so the group sort of learns the content in part through videos and discussing those. And that's that reflective discussion. And so they're talking about what they're seeing in the video, they're talking about the didactic content, and also then like, how does this relate to me or us? There is a lot of interactions. So a lot of like posing a question and encouraging reflection and wondering and curiosity and sharing that. So yeah, I would say it's, you know, the way the sessions work or run, try to parallel what we're encouraging the parent to do with their children. So like we want as facilitators to really have a wondering stance and a reflective stance, and to allow a lot of space for caregivers to sit and wonder and reflect during the group. So this is not a teaching orientation. You know, we're not the experts, and we're not doing like a parent training, which is, you know, a lot of what people do, clinicians do, is parent training. We teach. Here's all the stuff you need to know. I'm going to impart my knowledge on you. This is not how this group goes. This is like a really like, you know, like a space to reflect and be quiet and listen and think and talk and share. And so we want to give that, or have that be the way the sessions feel and run, because that's what we want them to be like with their children, is to be have that reflective capacity. Okay. Also, there is a focus on early literacy for a lot of reasons. I mean, just because it is so important, first of all, for child development. It's so important for school readiness, but we also know reading and sharing stories and sharing songs promotes secure attachment. It gives the parent and the young child like a close, connected. Usually when they're little, you're also holding them to read. Like, so there's just so many benefits of this during early childhood. And I don't know if everybody has seen, but you know, we even have people coming into the NICU and holding premature babies and reading books. It's not because premature babies can learn to read. It's because you have the holding, you have the close physical contact, you have the face-to-face interaction, and you have language being spoken, which is super, super good for development, even in a premature baby. So that is another big part of the program. And they have a beautiful list of books that are used. Here's a couple of the examples. And this was one of we were so happy about this. I'll just say on a side note, we were so happy about this when the trust fund funded us for a second year, which we're currently in. We were able to budget in the set of books that are used during the group, and each participant gets the whole set of books. And so and it's like a gift, you know, part of a gift we give them. And so as we go through the group, you know, 1 week, okay, this is what we're going to be doing. And we actually pull the book out, and you can do that virtually, by the way, you know, show like the book being read virtually. And this is like, what do we think about this book? I mean, it's talk, whatever, but they actually then have the book to use. So it's really awesome that we were able to do that in the second year. And then there's, a wrap up at the end. Okay. This slide is so important. Well, okay. Let me keep going. So I know we're going to have time for comments, but I'm just so sorry. I'm going to keep going, but you team members who do this all the time with parents, you can pipe in. Let me just get through the rest and then we'll get to discussion. Okay. So this is the last couple slides. I just want to let people know how it's going because this is really, really important, obviously. So like I mentioned before, we, just like the model is meant for, we include any caregivers of young children. I mentioned we do go up to 6 years. And they are coming to our center for some sort of health care. So usually we get them mostly from the pediatric clinic. We've had a few from the women's clinic. Most of them are coming through the pediatric clinic, we're for well child and sick care. And, we have been promoting this, promoting. I mean, we're sort of a broken record promoting this with all of our pediatric healthcare colleagues. Tell parents about this. We have flyers everywhere. And it has really started to gain momentum. And I hear from my colleagues who are tracking all the referrals that our referrals are like going up. So I would say it took about 12 to 18 months for it to like really stick. But it's sticking now and people are remembering and we're getting lots of referrals. So caregivers can see a flyer and they can call themselves. They do not have to be referred by a healthcare provider, but so they could self-refer. Most of ours come though because a clinician working with the family says, hey, we have this program called attachment vitamins. You're telling me about some stress you're having with parenting or some postpartum depression or whatever it is. Would you like them to contact you? And then if a patient says yes, most of them come that way. Another way, most of them comes that way. Chris Cipolla, who's one of our facilitators for attachment vitamins, also does a lot of outreach to parents of young children at our clinic. And so she is talking to a lot of parents and then if appropriate, we'll tell them about attachment vitamins. So that's who we're serving. Here's a little bit of demographic characteristics of people so far. On average, caregivers have been about 30 years old. I think, I'm not sure you guys can correct me. At the time I looked at the data, all had been biological parents, but I'm not sure that that's true anymore. But if we have non-biological parents, it hasn't been a lot. Most of our families, I mean, definitely over 90%, maybe even closer to 95%, who have participated in our program have self-identify as Black or African American, and that's consistent with our population we serve at the healthcare clinic. Most of them are single, never married. A majority are using Medicaid. Average family monthly income there, we've got some range, but generally you can tell from being Medicaid eligible that they are generally low income and have 3.5 people on average. So just to give you a little glance at sort of our patient, this is all very representative of our bigger patient population. And then in order to track how the program is going, we ask people if they would be willing to fill out some questionnaires before the group and then after the group. And so our team does these pre and post surveys. We don't force people to do the paperwork. We work with our institutional review board with anything that is involving evaluation and just from requirements of them. Understandably, we can't force people to fill out paperwork. So this is voluntary. Not everybody does it, but we do try to ask everybody to fill these out. So we really have been focusing on what we hope people gain, which is to promote and foster resilience. We have individuals fill out the parenting sense of competence questionnaire and the protective factors survey, measuring, again, sense of competence and confidence in the parenting role, and then a number of protective factors that are covered by the PFS, which I think this group is probably very familiar with. And then we also want to track the quality of the parent-child relationship. And also, you know, I mean, this is sort of core to the trust fund and prevention programs is reducing risk for child maltreatment. We hope to do. And we use the Parenting Stress Index short form to measure the relationship and the stress in the relationship, and the brief child abuse potential inventory, which screens for risks related to maltreatment. Okay, there's a lot of numbers, and you don't need to, you know, look at every single one. I'm going to highlight some things here. So first, from our goal of fostering resilience, this first column, pre, is the score before they did the group, and then post is their score after the group. So if you just look at those two, oh shoot, hold on, sorry, side by side, you know, what we want to see is satisfaction going up. So we see 33, 36, efficacy 34 to 36. And I know these numbers don't mean anything in and of itself right now. I'll point out what it means, but we're looking at just sort of trends here. Total parenting competence goes up from 68 to 73. This is all great because we want all these things to go up. So then in terms of protective factors, we have like family enjoying each other. You know, we enjoy being together, family fun, going up from 310 to 352. Nurturing attachment, just a little bit. Social support, a little bit. Actually, that's a lot. It ends up being a lot on that scale. Support with caregiving or taking care of children, like, so can someone help you if your kid's sick? And then concrete assistance, so sort of material needs. So take home number one is that all of their scores are higher after participating in the group than they were before. Now, we do want to be sort of cautious. We did run statistics. Well, are these like significant differences? Like they're all going in the right direction. Are they significant? And we look at that two different ways, which is the significance number, and then what we call fancy statistics, we call effect sizes. We have a pretty small group of people so far. And so that does influence how you can look at statistical significance. So really the most meaningful way to look at this is the far right column, the effect size. And what we're seeing, even though sometimes these numbers look like a really small increase, statistically, they're actually pretty big effects. And so anything bolded where I say large or moderate, moderate to large, those are the things that are like improving the most. So the ones that are improving the most are satisfaction in parenting, like enjoying parenthood. I would say the total sense of competence, that moderate effects are a big deal. You know, they're meaningful. Family enjoying each other, that had a moderate to large effect, and having a feeling of having emotional social support. Those were the biggest effects in terms of this sort of fostering resilience and protection. Okay, let me show you this one because these are even bigger effects actually. So this is the parent-child relationship and the abuse risk. So in this case, we want these numbers to go down. We want parenting stress to go down, and we want abuse risk to go down. So we see the numbers in the second column all going down quite substantially, actually. And if you go all the way to the far right, all of these effects are moderate to large or very large. So what this is telling us is that, you know, granted in our small group of people so far, we are seeing really meaningful reductions in parenting stress and risk factors for child abuse. The last two rows on the bottom, the brief child abuse potential inventory, that measure, you can get like a total score, but you can also, there's sort of like cut points for like, this is a risk, this person's at risk. They have like this like score, like that is a threshold. And there's two of those cut point threshold scores for this measure. One is a score of 9, and one is a score of 12. So there's like a more severe one and a looser one. And so what we see if we use like the percent of people who were above, in the risk category, first of all, just at baseline, we had 2/3 of people who were above the score. That's like very big. That's like 2/3 of people met the threshold for being at risk. Now, this does not mean anyone's going to harm their child. Okay. We don't use that as a measure of like, you're going to harm your child. That is not how this is meant to be used. It's just saying this parent has a lot of risk factors, and, so probably some support's needed. We're not going to say anybody's going to do anything based on this. So just as a measure of risk only. But we see using the 9-point threshold that the percent goes from 67% to 46%. So it drops by 20 percentage points. And then the really high risk dramatically drops from 50% to 18%. So those are very, very, very meaningful reductions in risk based on this measure. And then our moms, and this is the last thing I'll say, because I know we are, I'm at 45 minutes about, these are just, we also ask people to list, we ask them what their feedback was, like, how was it? What was most helpful? What was least helpful? What would you like us to change? Like a sort of open-ended thing. Thank you, Chris, for pulling these out. These are just some beautiful examples, but we have many more. So moms, or I'm sorry, slipped into that word, caregivers, for example, said being able to connect with mothers who are experiencing the same things. I was able to open up and talk to the women. I had a mental breakdown and called one of the ladies, and she opened her house to me, and I spent the night there. Building moments of connection with the child, not saying stop or no so much. Her children, their behavior changed for the positive when choosing different words. I also notice how or why behaviors have meaning. Dealing with tantrums, using tools I learned in group. I have more patience with my son. Any questions or concerns that I had about my child, I was able to get answers or confirmation about it in the group. I was able to be open and honest and not feel any type of judgment. Made me a lot more aware of how I treat my son and how I look at him overall, aware and more willing to accept. So beautiful quotes that also illustrate qualitatively what the group meant to them. And last but not least, this is where I finally have their names, our attachment vitamins team. And thank you to the trust fund for helping make this possible for us. That's our phone number and our email and our flyer. And anybody is please welcome to reach out to us if you want to know more about the program, or you want help connecting with the trainers, or you just any other reason. And I'll stop there. And hopefully we have 10 or 12 minutes. And then if my colleagues too can put their videos on so people know who you are, who run the groups. Thank you.
Thank you so much. I do just want to open it up and see if there's any questions. And then maybe if we don't have any specific questions that bubble up right now, maybe the other folks from your team, if you just want to share some reflections related to kind of your direct experience working with the caregivers through this program.
Waiting to see if there are any questions. Hi, everybody. I wanted to add that as Alissa was reading those quotes, those were actually quotes from a group that I completed recently. And I just think that it's so cool that I know exactly who said each one of those. Mm-hmm. That's how, and Alissa is so amazing at the fancy statistics and the data and breaking this all down. That is so not my wheelhouse, but I love getting to see all these numbers and think about this. But my experience with it is so much more anecdotal and qualitative, largely in that one of the most valuable things for me to see happen when running these groups is the connection that happens between the parents who are involved. I think anytime any of us are trying to learn a new skill set or think about, new concepts, we're gonna be much more successful if we're doing that with supportive community around us. And that's what's happening for these moms, and that's what we're able to create for them. And it's very moving, and it's really quite a privilege to be able to see the way that they support each other in that learning. Something I just had to say.
Yeah. Thanks, Holly.
For sure.
Chris or Jasmine, you guys want to say any words? You guys do this day in and day out.
So I like the fact that we are not the experts, and that the parents help each other out and they'll give ideas and help problem solve with the other moms. They normalize a lot of behavior. They encourage each other. I just had a group yesterday, and the prior week was about, reducing using the word no and stop. And a couple of the moms, talked about how already they're seeing a difference. And a couple of the moms were like, this is such a bad habit of mine. I can't, it's hard for me to stop, to stop using those words. And just the encouragement that the other moms gave was just awesome. I can't even express enough how much this group helps the moms become better parents and really see their children through a different lens. They're not thinking of their children as bad anymore. That's completely like taken off the table. They understand that behavior is communication. They put their detective hats on and try to figure out what is going on with their child. And it develops a, closer relationship, I think, between the parent and the child. And they're a little bit more of partners, as opposed to, the mom being the all powerful, just, do what I say. So anyway, I feel very blessed to be a part of this team.
Jasmine, how about you? Do you mind?
Yeah, one of the things I really like about this group, or the way the material is put out, is like there's also points of bringing in like cultural influences that may be happening. There's prompts in there for facilitators to use, which like I've noticed like helps the parents or caregivers reflect on like why they might be doing things a certain way, which could also help them to maybe think about, like, reflect on like how to change that too, and also not like to blame themselves so much. I think that's also one of the great things about the way the material is, and having that mom support too, is that like, or parent support in the group, or caregivers, is that it a lot of times I've noticed, like in the beginning, parent or caregivers might be like blaming themselves, like why am I doing this? Like, I'm like a bad parent, my child's bad. But then by the end of it, they're realizing like, oh, that like not only is this like not entirely my fault, or like that I'm to blame for this, but like also there's something I can do about it. And there's like reasons why things have happened this way. And having that understanding just gives them some compassion for themselves and their families.
I think to add to that, I think the content is very empowering in that it highlights for parents the things that they're already doing right, that they previously probably didn't have the language or the external acknowledgement about to begin with. So they get to kind of like be reflective around, oh, I'm already doing a lot of these things that we're encouraging and talking about in the content of attachment vitamins. And so they get to feel that, I always say, like, you deserve to be, to have these, your role as a mother or as a parent is so incredibly important. You're shaping the world, and some of the things that you're already doing deserve to be elevated and highlighted. And so we get the opportunity to do that in the group. And so they get to move forward in the content from this elevated position, I think, right from the start.
I think piggybacking on Holly's discussion of empowerment, the moms recognize how they were raised, and they recognize the fact that they have the power to change how they parent their children. And I just find that really powerful.
Yeah. I think the built-in like moments of connection every week is also very helpful. And by the end of it, there's like at the end of the last sessions, like people are having so many, like you could spend like all session on it if you wanted to. And just that's like just one way of just noticing the change in them too, is it's like, yeah, there's these things I'm already doing, and like, and I can do more of them if I want. And it's not like, about taking your kids on a vacation, but just the small things that are actually really huge.
Mhm.
We did have one question in our chat come in. And Lisa wanted to know, are there any specific professional requirements to get certified to run the groups for attachment vitamins?
Okay, help me out here, you guys. I don't think so.
I don't think so either.
I do not think so.
Like, I don't think you have to be a social worker or therapist. Like, I think
Mm-mm.
you could be like a lactation consultant or something.
Yeah,
Yeah.
a
Yep.
community health worker.
A
Yeah.
community health worker. Yes, I think that is, absolutely true. And actually in one of our trainings, one of our hospital lactation consultants was so keyed into this. And she's like, I have so many moms or parents I would want to do this with. So no, I don't think it doesn't require an advanced graduate level degree. It doesn't require a license of a mental health license. So no, which is another beautiful thing about it, that it makes it so much more accessible.
Parents project
And
specialist sounds good too, for whoever just.
What does?
Someone just said a parent project specialist in the chat.
Yeah.
Like, sounds good.
yes,
Again, because you're not expert. I always say, like, hey everybody, I'm raising 2 teenage girls, but when they were small, like your kids are, I didn't have access to this information, and I would have really benefited from it. I would have seen my children and their development through a very different lens. So there really isn't an expert component. It's really like, so I can't imagine that there would be any kind of like professional requirements.
and even though mental health and trauma does come up, there isn't a deep dive into it like maybe you would be doing in a more therapeutic setting. This is again like a primary prevention parenting support program. This isn't therapy. Although, of course, we're talking about a lot of therapeutic things. But yeah, so that's great. I do think any of those roles could be trained and deliver this.
Okay, and then we had one more question come in from Tiffany, and she wanted to know, could this training or programming be available online to other families in the surrounding area, as she has families that don't live directly in the Cleveland area that she feels like could benefit from the programming?
Actually, the group that I'm running right now, there is, I don't know that one of the moms does not live in Cuyahoga County. She lives in Lake County. Probably about an hour away. So I don't think it probably matters where they're living at the time.
Our groups are run online. I don't think we mentioned that, but like our groups are online
They're
too.
virtual.
So, yeah.
Yeah.
And I think in our second year of funding, we got permission from the trust fund. Like our first year was just restricted to the patients we saw at the clinic. And it was, even though it was virtual, but we did want to broaden the access. And so our second year wrote that in and got permission to broaden. So I'm thinking everybody's in agreement here, our team, that yes, we could take referrals from outside of our clinic or even outside of Cuyahoga. And also we can help connect other people if they want to get trained themselves. It does require that online free training, but then the 6 hours, sometimes it's a little bit more than 6 hours if teams, they told us it could be up to 9 hours if teams have not had experience working with young children yet. Our team has, so we got the shortened version. But it was a very, very reasonable training cost, like extremely reasonable in my opinion. So it's, I think it's not, an agency or a clinic or, a couple people could go in on it and anyway, we got grant money, so we were lucky. But it's not like extraordinarily like out of reach at all. So we're happy if people want to like say, oh, this is something like at our clinic, we would want like 5 people to be trained to do this. We can give you the information to connect with the developers.
I have a feeling several folks are going to be reaching out to you and your team after today's presentation. I do just want to thank you, your whole team. Thank you all for sharing this exciting program. I know we've been supporting this for 2 years now, so we're excited that we built a lot of momentum, and it was just great to hear all of the updates related to implementation. Thank you everybody for joining us again during April Child Abuse Prevention Month. This program highlights exactly our campaign about being a hero through positive childhoods, promising futures. We will be hosting one more prevention webinar next week. I dropped that in the chat for anybody who has not registered yet. And then for those who need any follow-up items, we will be following up with you after today's presentation. So thank you again, and good afternoon, everyone, and we will see you all soon.
Thank you.